I'm going to be talking about benign and malignant non-mass enhancement, a case-based approach. This is going to segue nicely from Dr. Zhou's lecture. And so we've talked about this, but what has the highest positive predictive value for malignancy? Segmental homogeneous, focal clumped, segmental clumped, or linear homogeneous. So you can just think about this question and we'll answer it at the end of the session. So the objectives of today's session are going to be defining the BI-RADS definition of non-mass enhancement and review the published literature. I'm going to give some case examples of benign versus malignant etiologies of non-mass enhancement, and I will review the MRI features of ductal carcinoma in situ, invasive ductal and lobular carcinomas presenting as NME. So as we've talked about, breast MRI is the most sensitive modality for detecting breast cancer. And NME is a little bit different. It describes an area that's neither a focus nor a mass. It's discrete from the parenchyma. And the way I think about it is that it's this area of tissue that distorts the parenchyma or expands the parenchyma, which makes it different from background parenchymal enhancement. As we just discussed, the ACR BI-RADS lexicon defines NME by its distribution as well as its internal enhancement patterns. There's been changes to NME in the BI-RADS that was just reviewed, but I'll continue with the 5th edition of the BI-RADS Atlas. So the internal enhancement patterns are what does the NME look like? And so there are 4 categories that we just discussed. One is homogeneous, and this is going to be confluent or uniform. Heterogeneous is more non-uniform, random, and I look at it and I say, oh, there's intervening fat or fibroglandular tissue in here. Clumped has a more cobblestone appearance. I think about a string of pearls or a beaded appearance. And then clustered rings, as was just discussed, is more thin rings of enhancement clustered around ducts. And I have examples here of homogeneous, heterogeneous, clumped, that string of beads, and then clustered ring. So I'm going to go through some of these examples of the internal enhancement patterns. Heterogeneous, this is a 63-year-old woman with a prior history of right breast cancer. She's here for her screening breast MRI, and you can see that the arrows point to a more heterogeneous NME. There's associated distortion on the sagittal delayed images, and ultrasound-guided biopsy was performed, and this is invasive ductal with DCIS. And you can see here that there's intervening areas of fat or normal fibroglandular tissue. So as we talked about, clustered ring enhancement is a little difficult to differentiate from clump for me sometimes. This is an example of clustered ring enhancement with a benign pathology, and I have a really nice pathology comparison to it. So I think about the holes or the ducts as non-enhancing duct contents and debris. So these elements don't enhance, but there are rings around it, and this is going to be our periductal fibrosis, chronic inflammation, or the DCIS that's going to be enhancing. So this example is a focal area of clustered ring enhancement in the left subareolar region. This is a 61-year-old who came in with pain in palpable area. Her MRI and her her mammo and ultrasound were negative, and that's why we did a diagnostic MRI. And so the pathophysiology of clustered ring enhancement can be found in both benign and malignant etiologies, with the highest when it's associated with clumped. So how do you differentiate clustered ring enhancement and clumped? And it may not really matter as much. It just really is, you go by your most suspicious finding, whether that's the morphology or distribution. That's what should push you to biopsy. So this is a 44-year-old woman. She has a family history of breast cancer, and her screening MRI demonstrates predominantly clumped NME, as denoted by the arrows, with some possible clustered ring as well. And you can tell that it's difficult to differentiate. However, biopsy is indicated, and this ends up being PASH with some columnar cell changes. So now I'm going to pivot to distribution. This is also from the 5th edition of the BI-RADS Atlas, and I'll go over the distribution. So first is focal. I think about focal as a confined area. This should be less than a breast quadrant in volume. Linear is more arrayed in a line or a line that branches, and this elevates your suspicion for malignancy because there may be some ductal involvement. Segmental, which has our highest positive predictive value for malignancy, that's going to be in a triangular or cone-shaped appearance with the apex towards the nipple. Regional is more than one ductal system. It's going to be at least a quadrant. And multiple regions are two large volumes of tissue and oftentimes separated by normal tissue. This can appear a little more patchy in appearance. And finally, diffuse. This is enhancement that's randomly distributed in the breast, similar to mammography. So now I'm going to go over some examples of the distribution. This is focal distribution. This is a 62-year-old woman with a family history of breast cancer. She's presenting for her screening breast MRI, and you can see in 2009 on the bottom, and then compared to above in 2016, there is a focal area of heterogeneous NME with some intrinsic T2 hyperintensity. This was stable for at least 7 years, so this is benign. Linear distribution, so arrayed in a line. This is a nice correlative examination of a 74-year-old woman. She has a screen detected developing asymmetry at 9 o'clock, and you can see in the lateral and the CC views. There was a non-mass hypoechoic area that corresponded on ultrasound, and she had a breast MRI as well that shows linear clumped NME, and a stereotactic core biopsy was performed, and this is ductal carcinoma in situ. So regional distribution, this is going to be greater than a quadrant. This is a 54-year-old woman with a new diagnosis of left invasive ductal carcinoma, as denoted by the orange circle, and she was here for her extensive disease MRI. You can see that there is regional clumped NME on the sagittal and axial contrast-enhanced breast MRI. MRI biopsy was performed and demonstrated atypical ductal hyperplasia with intraductal papillomas. This is a high-risk lesion, and it was actually upgraded to DCIS on mastectomy. So segmental distribution, this has our highest positive predictive value, a triangular shape, cone towards the nipple, 61-year-old woman, left breast cancer, extensive disease MRI, and you can see that there is segmental clustered ring enhancement that ultimately MRI-guided biopsy was performed. This again was atypical ductal hyperplasia upgraded to DCIS on surgical excision. So again, segmental distribution, particularly with clumped and clustered ring enhancement, is going to be very suspicious and should undergo MRI-guided biopsy. So a diffuse distribution is often seen in background parenchymal enhancement, particularly when marked. This is a 27-year-old woman with a history of mantle radiation for Hodgkin's lymphoma. She's here for her screening MRI, and you can see a diffuse marked background parenchymal enhancement. And as Dr. Comstock mentioned, some of the areas do appear similar to clustered ring enhancement because of the fibrocystic changes of the ducts. So the pathology of NME is quite varied, and again, non-mass enhancement is different from masses or calcifications where you know what your target is. So benign etiologies, there are many, including PASH, usual ductal hyperplasia, columnar cell changes, radiation effects, fat necrosis. High-risk lesions, similarly, atypical ductal hyperplasia, complex sclerosing lesions, or intraductal papillomas with or without atypia, and of course malignancies, ILC, IDC, DCIS. So that's why it's important to understand what to biopsy and what not to biopsy. I'm going to go through some examples of benign, atypical, and malignant NME. So this is an example from a screening MRI. You can see that there is a 7 millimeter enhancing mass on the left. MRI-guided biopsy was performed and demonstrated PASH. The patient was placed in a short interval follow-up, and as you can see, at 2 years, there's an enlarging focal area of NME. And so she got off the BI-RADS 3 train, as I like to call it, and it underwent wire localization and surgical excision, and this again was PASH. But despite the prior benign biopsy, if a finding is growing or new, then it's important to repeat biopsy for histopathology confirmation. So high-risk NME, this is a complex sclerosing lesion, 37-year-old BRCA mutation. She has this subtle area, focal asymmetry with distortion on mammography. An ultrasound was performed and there was no sonographic correlate. Because of her high-risk status, she also had a screening MRI, and you can see that there is focal clumped non-mass enhancement corresponding to the mammographic architectural distortion, as denoted by the blue circles. This was well seen under mammography, so underwent a stereotactic guided biopsy, and this is a radial sclerosing lesion or complex sclerosing lesion. So malignant NME, this is a nice case of invasive lobular carcinoma. So she has a subtle area of distortion on her screening mammogram in the central outer breast at posterior depth. A correlative ultrasound was done, and there is an irregular hypoechoic mass, invasive lobular carcinoma, well differentiated. But interestingly, on physical examination, the surgeon noted that the area was much bigger than on the initial imaging and recommended an extensive disease MRI. So I want to emphasize that ILC is a nice use of MRI because mammography is less sensitive and specific for detection, because its growth pattern in that sheet form is going to make it less visible or sometimes occult on mammography. And here you can see that is the original regular spiculated mass corresponding to the distortion. But the more you look, the more you can see. You can see that she has more regional spiculated masses with intervening NME, and this was all invasive lobular carcinoma, and the patient underwent a mastectomy. It's also important to compare what you have on MRI with mammogram and ultrasound. All our imaging tools are multimodality, and I say that one doesn't exist without the other. So this is a nice case. This is a 68-year-old woman who had left breast pain and a clinically palpable abnormality along the silicone implant. So she initially came to us prior to a mammogram or ultrasound. She went straight to MRI, which I'll talk about later is not the appropriate use. But you can see here she has this more heterogeneous, even clustered ring appearance in the segmental distribution abutting the implant. And you can see it as well enhancing on the axial views. So the radiologist thought this might be due to her rupture, a rupture of an implant. So what they recommended was actually a mammogram and ultrasound, and you can see here that there's extracapsular rupture of the implant with free silicone. We have the snowstorm appearance under ultrasound and high-density material on mammography. Here's another nice example of correlating the mammography and the MRI. So this is a 37-year-old woman. She has a history of Hodgkin's lymphoma. She's status post-radiation treatment, and she had a screening MRI done, and there is segmental clumped non-mass enhancement in the upper outer quadrant. She luckily had a mammogram the same day, and on mammography, there are suspicious pleomorphic calcifications in the upper outer breast corresponding to the NME nicely. So she had a stereotactic guided biopsy performed, and this is DCIS. So now the question really is, how do we differentiate benign and malignant non-mass enhancement? And this can be incredibly challenging. And so I have some tips that I use when I'm looking at my MRIs to help differentiate or decide whether something should undergo biopsy or not. So I look at the distribution. Is it a focal distribution? Is it segmental? Is it diffuse and bilateral? And especially if it's segmental, then I recommend an MR biopsy. I also look at the internal enhancement patterns. As we talked about, clumped and clustered ring enhancement have the highest positive predictive values. I look at the T2 hyperintensity, but I say be aware. I have some pitfall cases in here that shows that T2 hyperintensity may lead you down the wrong track if you use that as your sole indicator of benignity. Is there fat on the T1 pre-contrast fat-suppressed images? And as Dr. Joe nicely mentioned today, is it BPE? Look at the contralateral side, take advantage of your priors. Is it waxing and waning? And ultimately, does it look different from the rest? If you have a focus or a finding on one side, Carefully scrutinize the rest of the breast and the contralateral side. Ask yourself, does this really look different from the other side? So, interestingly, we have now instituted a second opinion process for all our breast MRI biopsies in order to help improve our PPV. So any case that's going to be recommended for MRI biopsy is reviewed by 2 other radiologists before going forward. So I had a nice selection of difficult cases that I'm going to share with you today. So this first case is a 38-year-old woman with a BRCA1 mutation. And so the things that I mentioned that I look at include distribution and internal enhancement pattern. Is there T2 hyperintensity? And I look at the same breast and the other side. Is it a solitary finding, or are there others that look similar? So in this case, this is a focal area of homogeneous enhancement. Does it have T2 hyperintensity? No. And it is a solitary finding. She's a high-risk patient. She is 38 and is BRCA1. So this underwent MRI-guided biopsy and was found to be ductal carcinoma in situ. So non-calcified DCIS accounts for about 10 to 20% of DCIS. These often are lower grade with a better prognosis, and when found on mammography or ultrasound are likely to be symptomatic when compared to non-calcified calcified DCIS. Why does DCIS calcify? Usually it's a combination of passive and active bone matrix processes. And on imaging, we just reviewed what it can look like on MRI. Just a reminder, on mammo, it may be a mass or a distortion. On ultrasound, I call it the pseudocystic appearance, where there's distension of the terminal ductal lobular unit by DCIS. So this is our second case. This is a 36-year-old asymptomatic female with a history of Hodgkin's lymphoma and mantle radiation, and she is here for her screening MRI. And so this was prospectively assessed by the initial radiologist as heterogeneous NME in the upper outer quadrant. But when you look closely, you can see that this is picture framing appearance. You can see that it's coming in from the periphery, and as well there's symmetry to the other side. And you can see on the sagittal delayed images, it doesn't look different from elsewhere in the breast. So it's important to become comfortable with background parenchymal enhancement and the different ways that it may appear on MRI. So I know some of these cases were reviewed today, but this is asymmetric background parenchymal enhancement. And interestingly, this is what is referred to as tamoxifen rebound. So this is a 46-year-old woman. She had a history of left breast cancer, status post-BCT, and tamoxifen was stopped the year prior. And so you may notice that there's new asymmetric background. Look at the patient's record. Was she on tamoxifen and was it stopped? And then you're going to have that rebound effect. Here's another example of background parenchymal enhancement more in a regional pattern. This is a 32-year-old with a history of right breast cancer, status post-lumpectomy and radiation. So you have asymmetry of the background enhancement due to radiation treatment. So background parenchymal enhancement, it's commonly bilateral, diffuse, and symmetric. As we talked about, the levels can be minimal, mild, moderate, or marked. And there are diagnostic dilemmas that come into play, especially if you have multiple enhancing foci or these larger focal areas. And they may be interpreted as NME. And if they are, they should be managed as a focal lesion. And as Dr. Comstock mentioned, I do like trying to plan these biopsies within the menstrual cycle if it's not an emergent extensive disease MR, because then you have a better chance of determining if it's going to be NME or just BPE. So here's an example. So we have what someone thought as a focal area of NME in the right breast. And if you look, there is T2 hyperintensity associated with the finding. And I like to look at the MIP. The MIP helps me determine bilaterally, does this look different? Is it a solitary lesion? And if you look closely, you can see that in other areas of the breast and the contralateral side, there's very similar appearing enhancement. So this was passed as background parenchymal enhancement. In contrast, this is a 31-year-old woman with a BRCA1 mutation. You can see that she has on her MIPS marked background parenchymal enhancement and a more focal area of NME on the left side. There is some mild T2-associated hyperintensity, but on the subtraction images and the kinetics, you can see this stands out. So again, we have segmental NME, some mild T2 hyperintensity, but it does look asymmetric from the contralateral side. It has persistent kinetics. This underwent biopsy, and luckily for the patient was benign. It was PASH and usual ductal hyperplasia. However, I would still biopsy it, even in retrospect now that I know it's benign, given the fact that it's asymmetric and she is high risk with her BRCA1 mutation. So kinetics and non-mass enhancement, there's mixed data on the use of kinetics with NME. A study by Kim et al. Found that DCIS, regardless of distribution, demonstrated non-suspicious kinetics. So always look at your most suspicious finding. If that's morphology or distribution, that's going to be more a reliable predictor of malignancy than kinetic analysis. And this is a really nice example of a 65-year-old woman who had prior BCT with right ILC, and you can see there's new homogeneous segmental enhancement in the lumpectomy bed, and there's absolutely no kinetics in the area. This underwent MRI biopsy and was an ILC recurrence. So this is case 4. This is a 63-year-old woman, has a history of BRCA2 mutation and left breast cancer treated by BCT. So you can see that overall the enhancement in the left breast is less, although it's very minimal or mild in the right breast. And if you look closely, there is an area of segmental clumped NME in the right breast. There is some mild T2 hyperintensity associated with it, but what makes it different is that it was asymmetric. It does have some washout kinetics to it. So despite the T2 hyperintensity, we did sample it. It ends up being apocrine cysts. This is benign and concordant. Again, even in retrospect, looking back at it, I would still biopsy it because you have asymmetry, it's segmental and clumped. So I mentioned about T2 hyperintensity in malignancy. It's important to be cautious about this. This is a nice example of a 46-year-old woman with a BRCA1 mutation and right breast cancer in 2004. And you can see that there's linear clumped NME in the left breast. And you can see that there is associated T2 hyperintensity within this area. So you have to go by your most suspicious features. Here you have a suspicious morphology as well as a suspicious distribution. And this is high-grade DCIS despite the high T2 signal. Here's another example. This is a more obvious malignancy. She's a 63-year-old woman with a newly diagnosed left breast DCIS, and an extensive disease MRI was obtained. You can see that she has clumped NME with associated T2 hyperintensity. An ultrasound-guided biopsy was performed, and this is IDC with DCIS. So suspicious distribution, this is really important to make sure that you're using correct Bio-Rad's terminology with morphology and distribution. This is a 59-year-old woman. She has a history of contralateral breast conservation therapy. And the index examination, and this was in the report, it says linear non-mass enhancement with washout kinetics. So if I said to you linear, non-mass, washout kinetics, you should think to yourself, this should be biopsied. Unfortunately, it was put into short interval follow-up. And you can see here that it has grown on 6-month follow-up, so then underwent an MRI-guided biopsy, and it's invasive ductal carcinoma. Linear and segmental NME, high positive predictive value for malignancy, so these should be sampled and not put in short interval follow-up. This is another example where suspicious internal enhancement patterns as well as distribution should put you towards biopsy rather than follow-up. This is a 64-year-old woman with a BRCA1 mutation and history of ovarian cancer. She had what was initially termed as a focus on her index baseline examination in the upper breast. At 6-month follow-up, there was equivocal growth. I think personally I would have kept it in a BI-RADS 3 at that time just because it hasn't changed. But at 12-month, it was described as linear and clumped. However, biopsy was not recommended. This is the BI-RADS 3 train. It's hard to get off of it. At 24 months when she returned, it was now more segmental, given a BI-RADS 4B, and was found to be ductal carcinoma in situ. So we talked briefly about probably benign in breast MRI. What about NME? So there's very limited data to support the use of BI-RADS 3 and NME. The malignancy rates in the literature are all greater than 2% and actually range from 3.5 to 8.4%. And none of them use T2 signal as a predictor for malignancy. We talked a little bit about what could possibly be in the BI-RADS 3 category, but I would use it with caution. One category that it could be possibly used is for fat necrosis. So recurrence in the post-surgical bed after BCT has been estimated to be 1 to 2%. And so you can have enhancement due to recurrence, but there are post-surgical changes there. And this may look like a small area of fat necrosis and can be indistinguishable from malignancy. And therefore, it's prudent to evaluate the area and determine, is it fat necrosis or recurrence? So this is an example of fat necrosis. So this is a 48-year-old female, status post-breast conservation therapy for invasive carcinoma with ductal and lobular features. This is 7 years prior to this MRI. And I really like looking at my T1 non-fat suppressed images in the lumpectomy bed to help determine, is it fat necrosis or is it not? So this is her index examination, and you can see here there's an area of enhancement, a focal homogeneous area of enhancement adjacent to the lumpectomy bed. And if you look closely on the T1 non-fat suppressed images, you can see that there's internal fat. Given its appearance, it was placed in 6-month follow-up, and it has stable enhancement 2 years after the index examination. So enhancement related to fat necrosis has been reportedly persists up to 5 years after lumpectomy, so just be aware of that. This is another example of fat necrosis. This is a 57-year-old woman with a history of left breast cancer, status post-mastectomy, and a right reduction mammoplasty 4 months prior. So you can see here on the subtraction images, there's 2 areas of focal NME within the surgical site here with associated T1 hyperintensity. And this is at the lateral and medial margins of the reduction scar, so it was thought to be just post-surgical changes. She was followed with no evidence of disease to date. So evolution of a scar into a non-enhancing, relatively avascular fibrotic area may take longer. It can take up to 18 months, so just to be aware. So those are my cases, and we reviewed the morphology and distribution, and segmental clumped has the highest combined PPV for malignancy. So in conclusion, how do we differentiate benign and malignant NME? Look at the distribution, look at the internal enhancement patterns, beware of T2 hyperintensity, use your T1 pre-contrast fat suppressed images to see if there's fat in the area. Think about, is it BPE? Does it look different from the rest? And be aware of appropriate and inappropriate uses of BI-RADS 3 in NME. Thank you.